The following podcast is part of a certified educational activity titled Guiding Patients Through Cardio-Renal-Metabolic Conditions, the Essential Role of Primary Care Clinicians. Access the entire activity and complete the post-test at peerview.com/WZW860. Downloadable slides and practice aids are also available.
Hi, this is Jay Schubert from Torrey University, California, and the American College of Diabetology. Welcome to Guiding Patients Through Cardio-Renal-Metabolic Conditions, the Essential Role of Primary Care Clinicians. We'll first spend some time defining these conditions and their overlapping risk factors. Then we'll discuss how to screen for and treat this syndrome in a holistic way, consistent with the new American Heart Association guidelines. For our goals for today, during this presentation, we're going to learn about screening patients for cardiac, renal, and metabolic diseases that may permit earlier and more effective treatment. We'll talk about the vast amount of evidence that shows intervening in one cardio-renal metabolic disease can actually have positive effects on others as well. We know there's an important role in SGLT2 inhibitors that address multiple cardio-renal metabolic diseases simultaneously in patients with or without type 2 diabetes. And we'll discuss systems of care that are being developed to effectively manage patients with cardio-renal metabolic diseases. Let's start with strategies for early detection and intervention for CRM comorbidities in diverse populations. We know that cardio-renal metabolic diseases, also known as cardiovascular kidney-metabolic diseases, or CKM, so you'll hear me say CRM or CKM, are strongly interrelated and are associated with premature morbidity and mortality. We know that CKM syndrome includes multiple conditions, including obesity, diabetes, chronic kidney disease, cardiovascular disease, heart failure, atrial fibrillation, coronary heart disease, stroke, peripheral arterial disease, and even those who are at risk for CVD or those who have existing CVD. However, CKD or chronic kidney disease and heart failure are exceedingly underdiagnosed among patients with or without type 2 diabetes. And so we need to start thinking about this. Many patients with chronic kidney disease, heart failure, and type 2 diabetes are unaware that they have it. And we have guideline-directed medical therapies, GDMT, for chronic kidney disease, heart failure, and type 2 diabetes that can improve patient outcomes. But we have to reconcile the differences among the specialist-specific guidelines so that we can coordinate patient care in a way that makes sense in our exceedingly difficult and fragmented healthcare system. So let's talk a little bit about CRM comorbidities or CKM. So I think one of the things that if I start and look at this, they're all interrelated. But if we start up top, that we know that excessive adiposity, particularly truncal or visceral adiposity, is a driving factor for many things. We'll go off a little bit to the left to show that we know that's one of the biggest risk factors for a very common condition called metabolic-associated steatotic liver disease, and MASH. We go down in the middle, that excess adiposity is also a driver for inflammation systemically, oxidative stress, insulin resistance, and vascular dysfunction. So now you can start seeing that this will now branch out on the left-hand side to address and start to cause things like hypertension, dyslipidemia, metabolic syndrome, and even diabetes. On the right-hand side, we also know that can drive glomerular hyperfiltration, glomerulosclerosis, which then turns into chronic kidney disease and will feed back to these other conditions and worsen them as well. And you're going to see a closely associated metabolic chatter between the kidney and the heart. And so a dysfunction in the kidney can create a problem in the heart. A problem in the heart can change flow to the kidney and also create dysfunction. So it's important for us to recognize that while we often treat conditions in isolation, this is an opportunity for us to look at root causes and symmetries or synergies that we can address when we're treating one condition that could help another. And we know that these conditions are common. So as you think about NHANES data, you can see that there's many people that have type 2 diabetes. You got many people that have chronic kidney disease, many that have cardiovascular disease, but there's actually substantial populations that have both. And when they have both, they're going to overlap. And when they overlap, you really have to step up treatment and make sure that we're aware of these comorbid conditions so that we're choosing treatments that really can optimize the patient's, one, prevention, but then two, treatment strategies. So as we look at staging CKM syndrome, I'm going to highlight the new classification from the American Heart Association. And I really want to highlight that this is a global perspective, really kind of looking at this in disease prevention and really trying to do population health. So if we go to the far left, really, we'd like to see everybody stay at stage 0 where they have no risk factors for CKM, and we're preventing excessive adiposity, we're preventing hypertension, we're preventing diabetes, we're preventing dyslipidemia, heart disease, and kidney disease. This is going to be important. This is really where most effective treatment could be if we're able to do it early enough. But we have some work to do. So we probably see many patients in primary care in stage 1. We identify patients who have excessive weight, adiposity, or obesity, and we should recognize that that is part of the CKN syndrome, and really it's stage 1. So let's think of something that we can diagnose, something we can identify and speak with patients about, and then start to treat. If we're effective, we can then reduce the number of people who reach stage 2, who have established abnormalities. Maybe they got hypertriglyceridemia or hypertension. Many people will have type 2 diabetes, and some might even have chronic kidney disease. And so really thinking about what we can do here to, if we find this, to halt the progression. Many patients currently today will progress to stage 3, and so they may have subclinical cardiovascular disease. They may have subclinical heart failure. But I want to highlight, just because they don't know they have it, and we don't know that we have it, we know that they still have the very similar risk of chronic kidney disease and heart disease, even though it's subclinical. So this is one where really we're starting to get towards that waterfall. We really need to do something right away. And then finally, stage 4 CKM is really looking at patients with established end organ damage from the syndrome. And now we're managing this condition. So we have work to do in all of these stages, but we have a very important role in primary care to really start looking at those, particularly in stage 0 and stage 1, and see what we can do to prevent them from progressing. And we know that in a healthcare system that's rather complicated, people still rely on their primary care clinician and get seen frequently, right? And it is important to recognize that while there are multiple different clinicians in the system, we need to identify the important role of primary care in the identification and prevention and treatment of chronic disease. And so let's go to that far hand side and look at the prevalence of people with each of these conditions. We know that most of our adult population has overweight or obesity, and we could be doing things objectively to stage that. We certainly use the BMI, but we could be looking at waist circumference and even visceral adiposity as ways to measure it. We know with hypertension, we could do a better job with people doing home blood pressure monitoring or doing the proper monitoring in the clinic. Certainly, I think many people are familiar with checking blood pressure, lipids, and diabetes parameters. But we maybe be doing less than what we should for things like coronary heart disease. Are we doing some of the biomarkers for coronary heart disease? Are we looking for heart failure in the pre-symptomatic condition? And are we getting a full screening of chronic kidney disease that includes both EGFR and UACR? And while this might be a lot to do, it is important to recognize that we have lots of patients with CKM, and many of them are in stage 1 and 2. These are patients that we probably can see regularly in our practice, and we have an important role to really halt the progression at that level, if at all possible. As you can see, we still have low levels of stage 0. We are going to have to do that in a public health standpoint, and I'm grateful that we still have less than 10% with CKM that have stage 3 or 4. But we have work to do. And then just highlighting that while we know there are some common risk factors as it relates to CKM, we're going to start seeing maps that look very similar to the obesity maps that we saw in the previous decades, and even the diabetes belt maps. And so you can highlight here that based upon the darkness, the rates of people with CKM stage 1 on the far left, those with stage 2 or 3 in the middle, and those with stage 4 on the right. And so we have a high burden of people across the CKM stages to address, but there are going to be areas, and often these are social or structural things that may affect the risk of advanced CKM. And so we have to start recognizing that as an important role or factor when we're looking at risk and management of this condition. Now, for some of you, the identification of CRM or CKM may be new. This is something that's relatively new in the medical scene, but I would say that actually most patients are unaware of it as well. So this was a questionnaire really asking patients, a Harris poll looking at their awareness. Only about 1 in 10 had even heard of CKM. But if you ask them, many of them think that it's important for us not to be treating things individually. We should really try to find ways that we can treat things collectively. And they want to know about CKM and they want to know more about what they can do about it. And we have a very important role to, one, not only educate, but inform them about risk factors and management strategies. So this is something you're going to start seeing more and more public awareness about CKM as well. Now, I know the challenge of doing chronic disease management in the outpatient setting. And I've seen these HEDIS measures many times on the right. What proportion do we get to the blood pressure goal and the lipid goal and the A1C goal? And then when you put them all together, those numbers get quite small. I would say that one of the things that I found in my practice that made this a whole lot better was to say, I know that these conditions are common. And I really want to be a lumper, not a splitter. How can I put these things together and say, how can I address the root causes? And how can I pick treatments that are going to have a benefit on multiple different conditions rather than having a patient come in with 7 problems that I'm trying to manage in a 15-minute appointment? And so you can certainly find ways to stage your appointments and address different things at different times. But CKM is really an opportunity for us to say, let's see where we can get synergies, where we can get benefits across multiple conditions with preventive or treatment strategies. And as part of that, the American Heart Association came out with a presidential advisory in 2023 about CRM. And what I want to show here is in a subspecialty college, it's not only just managing treatments, but really taking a global perspective. So looking at, consideration on the far left, social determinants of health. Do people have access to therapies that work? What are the research gaps across populations across the United States? And are we maximizing interdisciplinary care as a critical part of this treating the syndrome? We also have to make sure that we're looking at proper education for clinicians and patients and caregivers, making sure we know that obesity management is central to all of these conditions, and finding ways to implement this in a variety of health systems that have different strategies but will need similar interventions. And then finally, going back up to that very global level, how do we support healthy living communities? Because if we have healthy living communities, we're able to address people even in that stage 0 of CKM. And that's really our ultimate goal, is to move everyone from preventing upstream or potentially even going back down one stage. So let's think about the important role of primary care as it relates to CKM mortality. We know to have this global approach, we're going to have primary care access. So this is really showing you on the bottom, look at the dark blue from left to right. When you have high levels of primary care access, going to the right to lower levels of primary care access, now match that with the top graph and look at CKM mortality. Those levels that have high primary care access have the lowest levels of CKM mortality. And then on the right, you can see those areas that have low primary care access have much more of that red, and they have much higher CKM related mortality. And so it's important for us to know that regardless of what stage someone's at, they have primary care is going to have an important role in not only the prevention management, but the prevention of mortality in this condition. We also know there are factors that are beyond the healthcare setting that are critically important in all of our chronic diseases. So this is really looking at cardio-renal metabolic syndrome and its relationships to social determinants of health and mortality. And really, what I want to highlight here is that you can see down to the county level that we can actually start to use things like poverty or food insecurity as a marker to say this person's at higher risk for mortality. And while we may not be able to fix that alone in the clinical setting, I do think it's important to recognize that we might need to give different resources to different people based upon their social or structural determinants that might complicate their care. So this is going back to the American Heart Association guidelines and looking at a socioeconomic model for a cardio-renal metabolic syndrome. And as we think about this in primary care, we have that individual on the bottom, and they're going to have genetic and current health conditions. But we know that some of the modifiable behaviors that are typically seen at an individual level are actually strongly influenced by the people around them. So who are their family, friends, places of worship, work sites, because they actually influence some of the things that might be the behaviors that put people at risk. We know that we need to build healthier communities that support these health behaviors, and we need to recognize those other factors, such as economics, social needs, and resources that will make us really optimize the use of healthy relationships and communities to minimize health disease. So how do we build this into our practice? And I can tell you personally that we actually took a deep dive into social determinants of health in our practice. And there are many tools here, and they're all listed for you. As a family physician and diabetologist, I've used both the AAFP Everyone Project and the Prepare kit. And I think if you're new to this, I'd really encourage you to take a look at these. The one I would highlight is the AAFP one is free and open to anyone. There's no cost to it, but it is a little bit shorter. And so you can decide what's going to be the right match for your practice. But even taking just a minute once a year and doing one of these tools for your patients really can give you great insight to what are the resources and challenges they might be experiencing. So how do we do some early screening, right? I kind of talked about stage 0 and stage 1. So I think it's important to recognize that we could actually start this in children or in those that are less than 21. So I think first of all, recognizing normal developmental milestones, trying to make sure that we have age-specific height and weight graphs, and that we're recognizing excess weight and adiposity even during child and adolescent years. I think it's important to recognize that if someone has a family history of cardiovascular disease, that there are things that we can address in a family-based approach to help reduce some of those risks for the younger people. And then as it is clinically important, and sometimes you're going to be screening for things like elevated blood pressure, elevated lipids, even those people who we used to traditionally not think of as being at risk. And I would highlight, if you find someone that is young at risk, we often think about that 10 to 15-year duration from first abnormality to major complication. It's very important to do early screening, because the last thing I want to see is a bunch of people in their 20s that actually have chronic kidney disease or hypertension or diabetes. And we certainly have seen these conditions move to younger populations. And so I think it's important for us to be aware that our work starts even when people appear to have limited or no risk factors. When we're looking at adults, again, still recognizing that important factor of social determinants of health, as we would in families and kids as well. Think about adding that waist circumference to your annual or each of your visits so you can assess adiposity a little bit better. Make sure that you have a strategy for managing things like blood pressure management, screening for diabetes. And also, I would add, for any patient who has excess adiposity or metabolic syndrome or diabetes, think about also screening for MASLD or metabolic associated steatotic liver disease. It is incredibly common. It's 30% of the world's population, and it's probably more than 65 or 70% of people with excessive weight or type 2 diabetes or metabolic syndrome. If we have someone that looks like they have hypertension or diabetes, let's make sure we do full comprehensive CKD screening, which means we're going to check for both EGFR and UACR at least annually if it's normal, and maybe even more frequently if it's abnormal. And then we're going to start seeing more and more use of other tools to check for cardiovascular disease. This may not be entirely mainstream widely, but it has been more and more recommended that we consider doing things like coronary artery calcium scoring, considering maybe even things like lipoprotein little a or ApoB screening, as we're trying to really triage and individualize who has more risk for atherogenic abnormalities, more than just the lipid panel alone. So what are some of these tools? I've kind of highlighted some in the last slide, but we're going to take a little deeper dive. So as we think about height and weight, we used to do that alone. We all have probably implemented BMI into our annual vitals or into our individual visit vital signs. It's important to recognize that there is a J-shaped curve for this. There's certainly a weight that could be too low, but we've gotten pretty used to people having BMIs greater than 25, and those from Asian backgrounds with a BMI greater than 23. And we may not even think that it signifies overweight, but it does from a BMI standpoint. So let's make sure that we classify someone not only by what we see, but also give a BMI, which is an objective measurement. Now, it's not a perfect measurement, and we know that muscle mass and body structure can affect that. But particularly in that overweight category, usually utilizing things like waist circumference, which can be done in your office very quickly, your MA could be doing that as well, can be an additional factor to really highlight our ability to identify people who have that metabolic or visceral adiposity and probably should have more aggressive monitoring and screening and potentially interventions. So then we also have kind of well-established and well-known standards in terms of glucose abnormalities. So you've got fasting, 2-hour postprandial, and A1C is 3 different ways you can screen. I want to highlight the 3 rows, though: normal, prediabetes, and diabetes. And I think while we have a good knowledge of that, what to do for those who have normal glucose levels versus diabetes level glucose readings, we really need to start thinking about what we're going to do with those patients with prediabetes. We do have evidence-based programs and interventions that have been shown to be very effective. And I want to highlight that really your cardiovascular risk is very similar for those with prediabetes and diabetes. In fact, a third of people are going to have a complication the day they're diagnosed with diabetes. And so I think we really start to think about, if we're taking a more comprehensive approach, what can we do earlier on? And we're going to talk about that. And then certainly blood pressure is something that we commonly do in our visits, but do we do it optimally? And I have to tell you, I know that we often are in a hurry. People come in and take the blood pressure very quickly. And so we might have an oversampling of elevated blood pressures in a clinical setting. There are very good tools to help make sure that someone can get their blood pressure checked correctly. And I encourage you to give your patients who have an elevated blood pressure a home monitoring kit and instructions, just like we can see here, about the right way to do it, right? So avoid stimulants, don't exercise before, make sure you're sitting and relaxed, your arm is at heart level, and that you are not crossing your legs, you don't need to use the bathroom, and that you really do this in a quiet place where the person's not talking, and take 2 or measurements each time. I think this is really going to give us an opportunity to start to see what is the true burden of hypertension, particularly when we see that in the community setting. Certainly, the blood pressure targets, while they have changed a little bit, it's important to recognize that we really do look at that systolic blood pressure as a driving factor for many things. And you can see that depending upon the society, sometimes we're getting them below 130, sometimes we're shooting down below 120. But that's going to be somewhat risk-based. And so I think it's important for us not to just say everybody should have one blood pressure, but to start triaging what might be that goal. So for example, on the 5th column or 4th column down, you've got low risk adults with hypertension. So really we're shooting for that blood pressure below 140 and below 90. However, for higher patients with cardiovascular disease or CKD or diabetes, I might be shooting for a blood pressure below 120 systolic. And so making sure that we have a target in mind for that given patient and their conditions is really going to help. So let's think about that screening for hyperlipidemia. We've had some variable changes in the guidelines, and they've been updated recently, and I want to highlight that. And it's important to recognize that sometimes we'll have a desired value and we'll have a high alert value where it might need immediate attention. So in general, we're shooting for the total cholesterol below 200. You can see that we have an HDL goal greater than 40 in men and greater than 50 in women, and that we used to use like a non-HDL goal, but now we're really moving more to that LDL goal again for the general population, trying to get it below 100. If someone has a little bit higher risk, including diabetes, we'll get it below 70. And if they're very high risk, we're really going to try to get that below 55. And this is really kind of showing that we have benefit of driving that LDL down further. And then certainly triglycerides, particularly in the person without diabetes, should be less than 150. But I really want to highlight this non-fasting because I do often do non-fasting triglycerides, and it's remarkable how many people have dramatic elevation of the triglycerides when they're not fasting. That's a marker of cardiometabolic disease. We should not ignore that, and we should address that because there are goals for that. On the far right-hand side, anybody who has an LDL above 190 should have immediate treatment. They're very likely to have a genetic-based dyslipidemia. And then certainly anybody with triglycerides greater than 500 does have a higher risk. And anyone greater than 1,000, we're really worried about pancreatitis. So those are things that you'll probably need to address that moment. So as we think about chronic kidney disease, again, I think many of us are already aware of the things that we should be looking for. I want to highlight the heat map because I use this and I actually have this in each of my patient rooms. When I look at this, I not only think about a G stage, which is the EGFR, but I also think about A stages. We do very well in the country measuring people's creatinines and EGFRs, but only about half of patients who should have some screening for albuminuria actually have had it done in the past year. So this is a call out for us to do more complete CKD screening and then being able to place patients on this heat map. And so I want to highlight that both a change in GFR or a change in albumin can be a significant risk factor for advanced disease, not only chronic kidney disease, but also cardiovascular disease. So your G stages are basically developed by the EGFR. So if the EGFR is greater than 90, that's considered G1 normal to high. And sometimes you will have hyperfiltration in our patients early on with diabetes or kidney disease. G2 is mildly decreased. That's actually where a lot of patients sit. As you start to get down to stage 3 and EGFR below 60, that's where a lot of patients who have chronic kidney disease are. So we divide that into G3A and G3B and really highlighting that because there are different risks and there are going to be some significant changes in treatments when someone goes from 3A to 3B. And then certainly G4 and G5 for those patients with significantly reduced EGFR. And you can see that even people with G3B, they're in the orange. That's actually one of the triggers that I use to refer. So this graph talks about referring at G4, but I will refer to a nephrologist at G3B. If we go across the columns, we have A1, which means there's normal to mildly increased urine microalbumin. It's less than 30 milligrams per gram, which is most commonly used in the US. When you look at A2, what we used to call albuminuria, you have moderately increased albumin, so 30 to 299 milligrams per gram in the urine. And even with a normal GFR, you can see that change increases the risk from green to yellow. And then if someone has severely increased albuminuria, or what we would sometimes call proteinuria, greater than 300 milligrams per gram, this is also abnormal and does give you a very high risk of cardiovascular disease and also should be someone that we refer to nephrology. And then maybe the last thing I want to highlight in this section is that at least I had not traditionally been thinking about screening for heart failure, but there are now guidelines both from the American Heart Association as well as the ADA about screening adults for heart failure when they have risk factors. And so you can look at whether you're doing a BNP or an NT-proBNP. These are tools that you can be using in your practice. You can certainly look at the use of echocardiogram, especially if the patient is having symptoms like a shortness of breath or mild edema. So you're trying to catch people early. And these are going to be people who typically will have risk factors. So they have metabolic syndrome, they may have obesity, they may have type 2 diabetes or hypertension. So we should be starting to think that if we have patients who have screening levels above what's listed on the biomarkers, first of all, we need to get our cardiologists involved. And two, we have evidence-based treatments that we utilize in primary care that can give those patients particular benefit. And I encourage us to consider not only referring, but starting some of the treatments even within the primary care setting, and recognizing that once you find something that's abnormal, your screening interval is going to increase. And then we used to do the atherosclerotic cardiovascular risk factors equation, and that's a fabulous equation, still widely utilized. Prevent equation is a potential tool to use for those patients who have risk but not established disease. And I think it really is great because it takes in the adult status without known cardiovascular disease, and it allows us to identify patients earlier and more comprehensively. So you're going to see things like what's their age, what's their cholesterol level, what's their blood pressure level. We add in smoking, we have lipids, but we also now have EGFR, we have the BMI, we have the UACR, and we even have the zip code. And so now getting back to those maps that we were looking at before, we're really taking a more population health and comprehensive approach to that patient and really saying, hey, can we identify people earlier? Now, patients, once they have established cardiovascular disease, you can look at their higher risk and you can use other tools for that. But this is a great equation to be utilizing in those earlier stages of CKM. All right, so let's talk about translating some of this evidence into that guideline-directed practices. And you'll hear us say guideline-directed medical therapy for patients who have CRM or CKM conditions. So as we think about the pillars of therapy for CKM syndrome, it's important for us to really look at this broad-based approach and know that while we may not use every one of these in every patient, they do have overlapping benefit across multiple conditions. And of course, anyone with chronic kidney metabolic syndrome, we're going to be looking at lifestyle therapies, maintaining a healthy weight or helping someone get back to a healthy weight, making sure we're avoiding things like toxins such as alcohol or tobacco use, limiting sedentary time, and maximizing things like physical activity that's walking or kind of lifestyle based, and then making sure people have a good night of sleep and reduce social isolation and connection, getting them good connections to the community. And should be doing that already for patients even before they have CKM, but reinforcing the value in CKM. Then as you go across different conditions in the CKM syndrome, you can see that on the far left, for those patients who have atherosclerotic cardiovascular disease or hyperlipidemia, we're very commonly going to use a statin and adding ezetimibe if they don't get the goal. For those patients with established cardiovascular disease, we'll add an aspirin. We have the use of RAS agents for hypertension in alone or with diabetes, and also for those patients with chronic kidney disease. And when we have heart failure, we might also use an ACE or an ARB or an ARNI. And so we have actually benefit in heart failure specific for that situation. SGLT2s and GLP-1s have broad-based benefits, and so we'll kind of walk through those. So an SGLT2 inhibitor is beneficial for type 2 diabetes, beneficial for atherosclerotic cardiovascular risk reduction. We have benefit for both heart failure with reduced ejection fraction and preserved ejection fraction. We also have benefit for chronic kidney disease with and without diabetes. And so you're going to see that these agents are going to be utilized across different medical conditions and may be started for you in primary care, but also might be started by the cardiologist, the lipidologist, or even the nephrologist. GLP-1 receptor agonists and dual incretins have benefits again for type 2 diabetes, obesity. They probably are the largest our most effective pharmacologic treatment for the reduction of obesity. Some of these have proven benefit in atherosclerotic cardiovascular disease, heart failure with preserved ejection fraction, MASLD, and chronic kidney disease. And so you're going to see that these, again, might be started in primary care, or they might be started by the hepatologist or cardiologist or even the nephrologist. And then on the far right for diabetes, we know we have benefit with the use of metformin early on. Certainly we have other agents that have been proposed to be used in that pre-diabetes space. None of them have an FDA approval, but again, that might be one of the treatments you use. But we have treatments such as GLP-1s and SGLT2s that are taking more prominence in early management of type 2 diabetes because of their extraglycemic benefits. And then finally, when we're looking at those people with chronic kidney disease, we've already looked at an ACE or an ARB, we've already looked at an SGLT2 inhibitor, maybe an incretin-based agent. We know that the addition of finerenone can also be beneficial for those patients with CKD and type 2 diabetes. And we also have emerging benefit in heart failure. And so we can really start to see that these agents are now treating multiple conditions. And we really should be looking at how we start to put them together in a puzzle to really maximize treatment benefit for these patients. So, as we start to think about how we implement these treatment changes, let's look at kind of a staggered approach to prevention of atherosclerotic cardiovascular disease and CKM. So, thinking first at the very population level, let's make sure that we're optimizing those things that prevent the disease in the first place, that we have healthy places to live, we're addressing those areas of social determinants, we have safe places for our patients to exercise, be active, and getting healthy foods. Then we move to the kind of primary prevention space, which is really kind of looking more at an individual level. Have we really optimized their lifestyle modification? Are we starting now to look at objective measurements such as blood pressure, lipids, and glucose, and making sure that those are either optimized or trying to get them back to normal? As we move to secondary prevention, we're still doing all the things that we mentioned above, but we might now be doing targeted treatments, such as using SGLT2 inhibitors or GLP-1 receptor agonists, and actually having maybe even a more aggressive target, trying to get that blood pressure a little bit lower, optimizing the LDL cholesterol. Maybe we're actually even looking at additional therapies. For those patients with that need tertiary prevention, they have established disease and even some of those complications. Let's make sure that we're doing guideline-directed medical therapy. We're getting to those very aggressive LDL goals, blood pressure goals that are reaching target, glucose goals that are reaching target, and we're maximizing those therapies with proven benefit, particularly those things such as SGLT2 inhibitors, GLP-1 receptor agonists, statins, aspirin therapy as needed, and really making sure that we're doing comprehensive team-based care. As we think about these agents, SGLT2 inhibitors and GLP-1s, you're probably pretty familiar with the benefits that they have in terms of weight loss, A1C reduction, and systolic blood pressure. Certainly highlighting that, in terms of weight loss and A1C, you might see a greater reduction with the incretin-based agents, but you do get benefits with both of these classes, and you get better blood pressure reduction with the SGLT2 inhibitors. As we're looking at the additional benefits of these agents, and I want to highlight that these agents are not just diabetes agents, not just agents for obesity, they have benefits across the board. You see that you've got benefits for both SGLT2 inhibitors and GLP-1s for the reduction in all-cause death. You've got reduction in these for MACE outcomes and cardiovascular disease. You've got benefits with multiple agents in the SGLT2 category for chronic kidney disease and heart failure. And you're starting to see emerging benefit in heart failure for the incretin-based agents. And so as we start to think about putting this all together, I want to highlight that, you're going back to the heart and the diabetes and kidney. We've got agents that can actually treat all of these benefits. And so the central role of SGLT2 inhibitors and GLP-1 receptor agonists are important because they do not only the intermediate outcome, but these end outcomes that are very important. Added on top of base therapy of statins and RAS-based agents, and sometimes we'll add MRA into them. So we have lots of things that we can be doing for these CKM patients to give them benefit. And then finally, if you're having trouble writing these medicines, you're not sure what the indication is, there are multiple clinical guidelines out recommending these therapies. And so you can see from the diabetes to the cardiac to the kidney organizations, both here in Europe, all are generally recommending the use of these agents, particularly SGLT2 inhibitors, for these different conditions. And you can even write that in your SIG that you're writing this medication not for just diabetes, but also, say, chronic kidney disease or atherosclerotic cardiovascular disease or heart failure. And that might actually help you get that medication covered. That being said, I know that there's still an underutilization of these agents in people with and without diabetes. And so I want to highlight that if you look at this, even in the most obvious condition on the right, someone has diabetes, they have heart disease, they have kidney disease, and they have heart failure, you still only have about 60% of those patients on a RAS-based agent and only 14% on an SGLT2 inhibitor. That's a treatment gap that we could address. And if you go down, you can even look at it for those patients, let's say, that have heart failure and CKD, no diabetes. These agents are still a benefit, but you can see only 53% are getting a RAS-based agent and only 4% are getting an SGLT2 inhibitor. So to start thinking of these medicines not just as diabetes drugs, but they're heart failure drugs, they're atherosclerotic cardiovascular disease drugs, and they could be chronic kidney disease drugs. And let's not forget the central role of lifestyle in the management of these patients. And this is something that really starts at stage 0. It means that we're preventing any known chronic medical condition or risk factor. And this is really the basis of primary care is how do we help our patients do that, like life's essential 8? Eating better, more whole foods, less processed foods, eating out less, being consistent in our caloric intake with our kind of metabolic needs, being more active, not necessarily being to a gym, but just actually getting out and walking more, being sedentary less. Certainly avoiding any form of tobacco or nicotine product, kind of doubling down on the role of sleep as an important aspect in the maintenance of health. Managing weight, which is going to be addressed by all of those things on the left-hand side, but also letting people know, even when they start to get the upper limits of normal or they're in the overweight category, to say, hey, there's something we can do to prevent this? I want to prevent you from going to the next stage so that you don't actually have higher risk. And again, that can be very effective. Screening for and managing abnormal blood pressure, abnormal glucose, and blood pressure when they are present. But that does require us to use our evidence-based screenings and then helping our patients to do self-management as well if they do have one of those conditions. So now I'm going to get to the American Heart Association CKM guidelines. And I want to highlight here that if you're looking at some of the different risk factors, you're going to have stage treatment based upon what their risk factors are. So at stage 0 or stage 1, stage 0, we're going to prevent adiposity. And stage 1, we really need to take that comprehensive lifestyle approach to prevent that person from going on to develop metabolic disease and thinking about a comprehensive weight management approach that includes both lifestyle, medications if needed, and surgery when needed as well. And we do know that we have pretty good evidence about what weight loss can be achieved with each of these strategies. And so let's be real mindful about if I have a patient that's got more than 20% weight to lose, my options are pretty limited to kind of high intensity medicines and surgery. That doesn't mean we're not going to utilize lifestyle as part of it. But I think because weight management is so hard, we have to kind of overshoot those goals and make sure that we know where we're headed. Because I think, putting someone on like a dietary change alone, a moderate diet change when they may have 100 pounds to lose, that's going to be frustrating. It's going to take too long. So we might have to think about how do we do that more aggressively? And again, we've got strategies here across the treatment spectrum that we can utilize on an individual basis. As we think about CKM and management of hypertension, again, we still have that central role of lifestyle approach. I think we recommend self-monitoring of blood pressure at home, make sure that we're maximizing the use of RAS agents and adding other agents as we need to that have benefit not only for hypertension, maybe other conditions, and that we are getting to that blood pressure goal based upon their risk factors. So as we look at the newest guidelines as it relates to hypertension from the American Heart Association for patients in CKM, we really had very solid evidence for some of our recommendations. So if a person in the middle there just has hypertension and type 2 diabetes, we're going to use our RAS-based agent, and then we're going to add thiazide or a long-acting calcium channel blocker, and that's got very solid evidence that's going to work for our patient. If the patient has hypertension, diabetes, and CKD, we want to make sure that RAS agent is on board and maximized, and then we can add other agents as it is relevant to the patient. If the person has excessive weight with overweight and obesity and hypertension, we're not only going to manage the blood pressure, but we can also look at things such as potent incretin-based agents such as GLP-1 or twin cretin, and even consider metabolic surgery, albeit that the data is a little bit stronger or a little bit lighter recommendation, but still trying to really prevent patients from moving upstream. As we think about lipids, again, we've kind of highlighted the new lipid goals, and we know that the statins largely are generic now, they're very cheap, and so make sure you know what your goal is for your patient. So you go to the bottom there, are we doing primary prevention and we want an LDL goal below 100? Are we doing prevention with patients with diabetes or a little bit higher risk? We're trying to get that LDL below 70. Or is this a high-risk patient and we really need to get that LDL below 55? If we go back up now, all of our patients should have a statin really based upon their level of risk. They're cheap, they're effective, they do a great job, and they do have benefits for reducing heart disease. If they don't get the goal, you could consider ezetimibe as your next treatment, or you could do combination if you have a long way to go. If your patient needs to get to those lower levels, you may need to use non-statin and other therapies, such as bempoic acid, the PCSK9 inhibitors, or really getting them to a cardiologist or lipidologist if those goals can't be reached. But I really encourage you in primary care to at least try to start doing that, because these are agents that we often can be used in our practice. Sometimes they have to be written by a subspecialist, but they are agents that we need to consider using earlier. Now, I often get questions about statin-related muscle symptoms, and I just really want to highlight that I really had this drummed into me when I was being trained that this is something we need to screen for, we need to look for. But the reality is actually, this is quite low. Less than 10% are going to have any kind of symptoms, and even less than that clearly have a very clear association with the statin. So if a patient starts to have problems, there's a lot that we could do. You could look at the same statin in a lower dose, or maybe even a lower frequency if it's severe. You could look switching to a different statin. Sometimes I go from lipophilic to hydrophilic statins. Those often help that. You could add a non-statin to the statin, such as, ezetimibe. You could look at one of those other agents. Or you can certainly bypass the statin if it's severe and the person has tried multiple agents and go to one of the non-statin agents. But we have lots of treatment options. Most of them are quite affordable, and it is worthwhile for us really to take the time to put them on the right intensity of statin right from the get-go, rather than starting low and going slow. And you're going to see a renewed focus on hypertriglyceridemia. So again, thinking about this as a marker of metabolic disease and cardiovascular disease. So we're going to do those same kind of things in terms of lifestyle modification, but recognizing that role of hypertriglyceridemia that should be reduced for things like metabolic liver disease, cardiovascular disease. And so we're going to start looking at adding agents that are specific to hypertriglyceridemia on top of those lifestyle changes. We've got a table here showing you the different agents and their ability to reduce triglycerides. And I always remind patients that the statins not only get the LDL down, but they also can help reduce the triglycerides as well. You've got other things such as fibrates and omega-3 fatty acids that are used. Niacin's not used so much anymore. And then you have some other agents that are newer, right? The bempoic acid, the PCSK9 inhibitors. And there's even newer agents that are coming that are going to be reducing the triglycerides to a very substantial amount. And maybe these will be used in cardiology or lipidology first. But I think it's important to know that we really can help these patients get to goal with the potency of the tools that we have available today. And then finally, when we look at managing CKM, looking at chronic kidney disease, we know that we start with doing proper screening with both a EGFR and a UACR, putting patients on RAS agents that have an abnormality of either one of those or hypertension. For those patients that still have problems, we should look at the use of an SGLT2 inhibitor with or without diabetes. And we often will add finerenone if they have persistent residual albuminuria. And these agents can be used together. And there'll be times where we're even adding a GLP-1 as well. And so these agents are complementary, and at least in post hoc analysis, they seem to have synergistic benefit. Cadigo has really talked about us taking a broad approach to chronic kidney disease, just like we did with the heart. So let's look at those baseline things. Are we keeping a healthy diet? Are we doing physical activity? Are we doing weight management? And weight management is a priority in CKD management. And choosing agents that will allow us to get control of the metabolic risk factor, but also improve the kidney. And you're going to see more and more emphasis of the use of SGLT2 inhibitors earlier in the patients who have chronic kidney disease so that we can maximize the benefit. If they don't get benefit with their RAS agents and their SGLT2 inhibitor, you might be looking at the use of a GLP-1 or MRA. All the time looking at not just the CKD parameters, but looking at glycemic control, weight management, blood pressure, as well as the kidney variables, and reassessing this frequently so that we know we're making progress. Not it's a one and done. It's we start and we monitor more frequently and make sure our therapy is working. And then with diabetes, we've kind of highlighted this throughout. We know that the diabetes, we want to try to get an A1C down to a level that's appropriate for their overall health. We want to make sure that we maximize the benefit of lifestyle interventions that can help with weight, blood pressure, lipids, and glucose. We're going to utilize agents that have proven benefit in these other conditions. So you're going to see a stronger emphasis on the use of SGLT2 inhibitors, particularly for those patients with chronic kidney disease, heart failure, or atherosclerotic heart disease. And you're going to see an emphasis of the use of GLP-1 or twin incretins in those patients with heart disease, metabolic associated steatotic liver disease, obesity, and emerging now in the CKD and potential heart failure space. So these agents are going to give you multiple benefit. And this is really kind of highlighting across the board there when you're looking at picking an A1C goal on the bottom. Your A1C goal will really be based upon the overall health of the patient, but then you can start choosing your agents that have benefits across the board. And so if you look on the top box there, you can see that you've got SGLT2 inhibitors that really are helpful across atherosclerotic cardiovascular disease, heart failure, CKD, a mild benefit for weight. And then you've got, and as well as hyperglycemia, especially if the EGFR is above 45. But then you also have GLP-1s that are often placed across the different conditions as well. You also will see a hierarchy of intensity of treatments based upon the current weight and what the goal is, or the current A1C and what the goal is. And so often you're going to choose more potent agents when they're further from their goal. When we look at SGLT2 inhibitors, we now have a bunch of them to choose from. This is really highlighting the FDA-approved indications as of current date of looking at what's indicated for benefit for CKD or heart failure. Certainly, they have benefit for type 2 diabetes. And the ones in the green circles have been approved for with and without type 2 diabetes. So this is really quite significant. When I'm writing these agents, particularly if I'm having trouble getting them covered, if I try to write the one with the right conditions, the right indications, I'll put that in the SIG, and that often helps the patient get the medicine covered. And there are agents that have benefits across multiple conditions, and this is really going to be something that's going to make the patient feel better, knowing that you're giving benefit for multiple conditions rather than multiple drugs for each condition. And then finally, some of these are starting to go generic. And I think that it's very important that we get our patients on this class of drugs. And if cost is the primary driver, if they have no insurance, let's look at a patient assistance program or consider which things might be the most affordable for them so that we can get them on an agent in that class if we can't hit the gold standard of getting them for the treatment that's indicated. Now, this takes a lot of work, right? I know that you all are looking at this and prior authorizations in your practice. It's important to have a team, right? So I have a kind of a team in each of my practices that look at one, prior authorizations or the paperwork, but I also have a team of pharmacists. And I think the pharmacist really can be an important team member for you all to think about optimizing therapy and even doing treatment titrations between your visits. And there's good evidence that things like medication therapeutic management or collaborative practice agreements are going to allow you to have better outcomes for your patients, better teamwork, but less work. So finally, we're going to talk about collaborative care for CRM conditions, and we have a fair amount of data to support the use of this. The American Heart Association has built an implementation guide that you can build for your practice. It highlights all the different healthcare clinicians that might be involved in the care of this patient. And really, you're going to build your team based upon the resources that you have available in your society or your community. And while it might be different for each, I think it's really important for us not to go it alone. This is a heavy lift for someone to do by themselves. And we do have evidence that when you start building teams, you really get, or cardiometabolic clinics, you do get better outcomes. So we're highlighting here just one study that was retrospective, looking at a team-based approach. And you see that they got better A1C reductions, they got more initiation of evidence-based meds, and they had benefits of both numerical benefits, but not statistical benefits between LDL-C and blood pressure changes. But this again is still providing the same treatment, but not doing it alone, but doing it as part of a team. Multiple other studies have shown that primary-based teams also are very, very effective. So again, 3 different studies here showing that you can look at the use of an primary care-based, team-based approach improves the uptake of GLP-1s, SGLT2s, statins, and RAS agents for those patients who are at high risk for advanced kidney disease and CKM. And then certainly we know that pharmacist-based team management have also been quite effective. And we have seen that when you have a pharmacy-driven algorithm, you really can get benefit in terms of reducing A1C, reducing lipids, and getting patients to goal quicker. And this has been shown both in the US as also in the UK as well. So one of the things that I've started to really implement in my practice is trying to take that healthcare beyond the space of the office and taking it into the community. We know community health workers, particularly certified community health workers, can do a lot to help us address that comprehensive management of our patient. They can do care coordination. They can do case management. They can help find areas to maximize education, and they can really help navigate not only the clinical space, but some of the social determinants that a patient might be experiencing. And so we're utilizing community health workers, one, because they're embedded in the community, they're trusted community partners, but two, they're a linkage between the clinical site and the community site, and really taking that healthcare into the community and doing not just individual, but community-based care. And the American Heart Association says maybe we need a new thing, maybe that CKM health coordinator. That might be a community health worker, it might be someone else, but really trying to lead that team and coordinate care. And that might look different depending upon where you're at. That might be a clinician in a very large healthcare system. It could be a staff member in an individual office. Maybe it's even a community member. But I really want to highlight here that a team-based approach that's going to be necessary for us to do that comprehensive approach and for us to start thinking about that. Now, I would love for this to be paid for. I would love for this to increase our reimbursement, and we'll have to see. But I think this does feel like it's the right thing to do. We just have to find a way to do that and sustain it. And if we did that, we actually then would be able to start looking at our patients and say who are low risk and who are high risk, and who needs to be referred to the team, who needs what team members. And so it allows us to get the right intensity of care for the right patients when we have a systematic approach and someone overseeing that. And we know that this is ultimately meant not only to improve individual health, but also trying to make sure that we're addressing that challenge between value-based care and volume-based care. You know, so many of us are being paid for the number of visits, but not necessarily the quality of visits. And we know that both are going to be important for the sustainability, but we really need value-based care to become an important priority so that we're able then to start focusing on what's going to improve both the person's quality of life, but reduce medical complications and the cost of their healthcare. The AHA has started a groundbreaking initiative developing essentially cardiometabolic and chronic kidney metabolic spaces and focused practices and trying to find ways to show that this will work. And I suspect you're going to hear a lot more about this in the next 4 years, where you're going to have cardio-kidney-metabolic centers that really are trying to optimize care and show the benefit of that, which I hope then will be widely implemented. So what do I want you to take from today? We know that cardio-kidney-metabolic syndrome is very, very common, and it's relevant to our practices. We know that we're seeing this regularly, and we can identify it earlier than we currently are. And the more we can be aware of this, the more we can communicate with our patients, the more we're going to have very effective early interventions. We need to be able to screen in that stage 0 and stage 1, address excessive adiposity earlier in the process, and then really start to say, what can we do to prevent someone from developing clinical disease, both through screening with novel and existing tests and biomarkers, but then also trying to treat to prevent the burden of metabolic-related complications, such as type 2 diabetes, heart disease, kidney disease, and heart failure, and MASLD. We have tools that sometimes were thought of as used in other conditions that we can now use for multiple conditions. So in the diabetes space, we have SGLT2 inhibitors and GLP-1 receptor agonists, but they're also going to be used sometimes for chronic kidney disease. They might be used for atherosclerotic cardiovascular disease. They might be used in heart failure. We have MRAs that used to be utilized only for chronic kidney disease, but actually have shown to have benefit in kidney disease, heart failure, and atherosclerotic cardiovascular disease. And then remembering things like RAS agents and statins that really, even though we've known about their benefits for many years, we have not optimized them. And we really should be optimizing them. And so while this is a lot to take in, what I want to highlight is that we have a very important role to be able to change not only our individual patients' health, but population health by taking this much more global approach, screening earlier, communicating more with our patients, and finding these guideline-directed medical treatments that can change our patients' morbidity and mortality. That concludes our discussion for today. I hope you found that the activity was informative in understanding how to diagnose cardio-renal metabolic conditions, and I hope you feel more confident about screening for and treating these interrelated conditions in your primary care practice. Please remember to download the slides and the accompanying practice aids. You'll find them very useful for both you and your patients, and thank you very much for participating.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PBI, PeerView Institute for Medical Education. This activity is supported by an independent medical education grant from Boehringer Ingelheim Pharmaceuticals Incorporated and Eli Lilly and Company. To access all materials for this activity, visit peerview.com/WZW860.